Hello, my name is Kara Hills and I'm a clinical pharmacist in the Heart Rhythm Clinic where I primarily work with patients who have atrial fibrillation. Today you're going to hear all about the antiarrhythmics that you will see in the electrophysiology lab and that patients may be taking to control their irregular rhythms. The antiarrhythmic classification system was developed by Miles von Williams in 1970. The system was based on the effects of the medications on the cardiac action potential. It has four main classes. Class 1 includes the sodium channel blockers, Class 2, the beta blockers, Class 3, the potassium channel blockers, and Class 4, the calcium channel blockers. There have now been new sections and subsections developed that include molecular targets, such as specific ion channels, and beta-adrenergic receptors are added into Class 2. In this presentation, we will discuss the expansion of Class 2, as you will see these medications in the electrophysiology lab. This is another slide with the classification system, but I thought it was useful as it has this phrase at the bottom, some block potassium channels, which I know I found useful to help remember the four main classes. So this is just for you to refer back to. Now I want to review the ECG and the ventricular cardiac action potential, as we will be talking about this a lot in the presentation. So at baseline we have phase 4, which is the resting membrane potential. When a cell is resting, it is in a negative state. What happens now is that sodium channels open. This allows sodium into the cell and makes the cell positive. This is depolarization and phase 0 of the action potential. In order to restore the negative state of the cell, the potassium channels open and potassium moves out of the cell, which starts the repolarization, or phase 1 of the action potential. Calcium also starts to move into the cell, and this balances the charges and causes the plateau you see in phase 2 of the action potential. On your ECG, you see the QRS complex while this rapid depolarization and repolarization happens. As more potassium continues to move out of the cell, you finish the repolarization, which is phase 3 of the action potential, and you're back at your negative resting state. The repolarization is the T you see on the ECG. Try to keep all this in mind while we discuss the antiarrhythmics, as how we affect these ion channels will affect the action potential and as a result your ECG reading. I want to define some terms you'll hear throughout this presentation. First, there is conduction velocity, which is the speed that the action potentials will move through the cardiac tissue. Next, you have automaticity, which is the heart's innate ability to spontaneously depolarize and generate action potential, which happens in the pacemakers, either normal nodes or abnormal tissue in the heart. And finally, the effective refractory period, or ERP, is the time after an action potential where the cell is unable to initiate another action potential. This occurs during phase 0 to 3, as you can see in the diagram. Class 1 antiarrhythmics are the sodium channel blockers. They block phase 0, or the depolarization of the cell. There are 3 subgroups that are divided up because they have different mechanisms or duration of action due to their speed of binding and then unbinding from the sodium receptors. The subgroups are Class 1A, 1B, and 1C, and we will delve deeper into these 3 groups in a few slides. Class 1 subgroups will work better at certain heart rates, so they are called rate dependent. And they are weak bases, so pH of the cells will alter their actions, with a more acidic environment enhancing their activity and a more basic environment diminishing activity. Class 1A consists of the drugs disopyramide, procainamide, and quinidine. These are the intermediate on-off sodium channel blockers because they have an intermediate binding and dissociation from the channel receptors. You can see in the diagram of the action potential how phase 0 is altered, causing an increase in the action potential duration, and this causes an increase in the effective refractory period. This results in an increased QRS and QT on your ECG. Class 1A drugs also slow the conduction velocity through the cardiac cells and decrease automaticity in the pacemaker. They block potassium channels more at slow rates. This subclass also has anticholinergic activity and depresses myocardial function. Quinidine and procainamide decrease vascular resistance, causing dilation. Disopyramide does the opposite, causing contraction due to increased vascular resistance. It is not often used as an antiarrhythmic, but more used in hypertrophic obstructive cardiomyopathy. Class 1A medications are used for supraventricular tachycardias, such as atrial fibrillation, but are not often used in the outpatient setting. They're also used in ventricular tachycardia and ventricular fibrillation, and especially used in Brugada syndrome. And just note that due to the wide QRS and QT, they are proarrhythmic. I'm going to go into more detail about procainamide, as it will be used in the EP lab for VTs and SVTs, and in the race clinic for the epinephrine and procainamide protocol, which is used to detect the cause of electrical disease in patients with unexplained cardiac arrest. It has adverse effects of severe hypotension, which requires frequent blood pressure checks. You will need to watch your ECG for changes we discussed before, such as widening of the QRS primarily, and widening of the QT and PR due to slower conduction and longer systole. If you see a greater than 50% widening of these intervals, then procainamide is stopped, or you can end up with arrhythmias. Other adverse effects are hypersensitivity syndrome, confusion, dizziness, and nausea or vomiting. Class 1B consists of lidocaine and mexiletine. These are the fast on-off drugs, as they rapidly bind and dissociate from the sodium channel receptors in depolarized tissue. They have a minimal effect on conduction velocity. You can see from the diagram that they shorten the action potential, therefore shortening the refractory period, and this will appear as a shorter QT on the ECG. They decrease automaticity in the pacemaker cells, and because they work best in depolarized tissue, they are most effective for tachyarrhythmias such as VT and VF. Due to the fact that they do not prolong the QT interval, they can be added on to other antiarrhythmics. Flecainide and propafenone are the strongest sodium channel blockers and make up class 1C. They are the slowest at binding and dissociation from the sodium receptors. They have the greatest impact on slowing conduction velocity and also decrease automaticity. You can see from the diagram that they change the slope of phase 0 the most, and this causes the greatest impact on the QRS of all the sodium channel blockers. They can increase the action potential duration by blocking potassium channels as well. They're used primarily for supraventricular tachycardias, such as AFib or flutter, or tachycardias with accessory pathways. They are used in VT when other meds haven't been able to work, for PVCs and for catecholaminergic polymorphic ventricular tachycardia. Flecainide and propafenone have adverse effects such as dizziness, headache, GI upset. They can also cause visual disturbance, tremor, sleep issues, and an unusual taste in the patient's mouth. They cannot be used for patients with ischemic heart disease, as these patients had increased mortality in studies. An echo needs to be done before using them to ensure the patients don't have left ventricular dysfunction, which can be worsened by the negative inotropic effects of these medications. The proarrhythmic effects of these medications necessitates close ECG monitoring for patients taking them. Here is an overview slide of all the sodium channel subgroups. You can see how they each affect the slope of phase 0 and the refractory period in a different way. Again, class 1C is the strongest and will have the greatest effect on depolarization and the QRS interval. Class 1A has the greatest effect on the effective refractory period. Class 2 used to be known just for the beta blockers, but now encompasses all the medications that are autonomic inhibitors and activators. They act in nodal tissue and affect the resting phase, phase 4, which is known as the pacemaker potential. This is a nodal action potential, which looks a little different from the ventricular action potential we've been talking about for class 1 medications. You can see how phase 4 is a spontaneous depolarization, also known as that pacemaker potential, that triggers the action potential when the threshold is met. The black line in the second picture is the normal action potential. When there is an increase in sympathetic activity, the phase 4 slope increases like the red line, and you will have an increase in the number of action potentials in the node. If there is an increase in vagal activity, you get a decrease in the phase 4 slope like the green line, and you would have less action potentials in the node. Class 2A is the beta blockers, which inhibit sympathetic activity by inhibiting epinephrine and norepinephrine. Beta blockers can be selective for the heart or non-selective. They will cause a decrease in the slope of phase 4, and it will take longer to reach that threshold. This will cause less action potentials to be generated and slow discharge of all pacemakers, whether in the node or ectopic. There will be a slowing of conduction velocity, a decreased automaticity, and prolonged effective refractory period. This will cause an increase in the RR and PR on your ECG. Calcium channels are indirectly blocked as well. Beta blockers are used for rate control in atrial and ventricular tachycardias, for long QT syndrome, and catecholaminergic polymorphic ventricular tachycardia. Class 2B are the beta receptor activators, so the opposite of beta blockers. This class includes isoproterenol. It will increase sympathetic activity, like the red dotted line shows here, and decrease the effective refractory period. This will cause an increase in heart rate and contractility. The ECG will show a decrease in the R and PR intervals. Isoproterenol is used in the EP lab to provoke ventricular arrhythmias. It can increase heart rate for bradyarrhythmias and reverse AV no block and torsade de pointe. The adverse effects that may occur include severe hypotension due to a decrease in mean blood pressure from vasodilation, arrhythmias, tachycardia, anginal pain, plus the other side effects listed here. Class 2C is the muscarinic M2 receptor inhibitors. It includes atropine, which you may see in the EP lab, hyoscine, and scopolamine. These drugs inhibit vagal activation of the heart. Decreasing the vagal tone will increase the slope of phase 4 as seen by the red dotted line in the diagram. This decreases the refractory period, increasing action potential in the node. This causes an increased heart rate and reverses AV block. You will see a shorter RR and PR on your ECG. Atropine is used for sinus bradycardia and for conduction blocks. Class 2D includes the muscarinic M2 receptor activators, so opposite of the M2 inhibitors. This subgroup includes carbachol, pilocarpine, methacholine, and digoxin. The M2 activators increase vagal tone, as you see in the dotted green line here. Again, this decreases the slope of phase 4 and increases the effective refractory period, leading to a decrease in the activity of the node. They will cause a decrease in heart rate and reduce conduction velocity. The RR and PR will be prolonged on the ECG. The M2 activators are used for SVTs and sinus tachycardia. Finally, Class 2E is the adenosine activator. Adenosine, like the beta blockers, decreases sympathetic tone, causing a decreased slope in phase 4, shown by the dotted green line. This causes the increased ERP, lower heart rate, conduction velocity, and longer RR and PR on the ECG. Adenosine is used for AV node tachycardias, ventricular tachycardias, specifically if cyclic AMP mediated, and to diagnose and treat reentry node SVT versus a flutter. Adenosine has many adverse effects, including several arrhythmias listed here, and it requires continuous ECG monitoring. It can cause anginal pain and pressure, shortness of breath, flushing, and nausea. There are many other side effects, but one most often described is the feeling of apprehension or doom and panic. This is because you're actually stopping the patient's heart, and they can feel this. Now we can move on to class 3 antiarrhythmics, which you may remember are the potassium channel blockers. This class has 3 medications: amiodarone, dronedarone, and sotalol. These medications block potassium, so they primarily affect phase 3 of the action potential, delaying repolarization. As you can see in the diagram, the delay in phase 3 leads to a longer refractory period, which will show as a longer QT on the ECG. Class 3 medications have a risk of proarrhythmia because of this long QT. Amiodarone is a complex antiarrhythmic with properties of all of the classes of antiarrhythmics. It's a fast on-off sodium channel blocker, and this effect increases over time. It has non-selective beta blocker activity and starts immediately with use and stabilizes over time. This can cause some of the initial dizziness patients experience. It is also a weak calcium channel blocker. The potassium channel blocking is its main effect though, and this increases with chronic use. That is why you need to have a loading dose of amiodarone, as the potassium channel activity will be stronger the longer you take it, and you won't need such a high dose in the long term. Amiodarone is used for SVTs such as AFib and Wolff-Parkinson-White syndrome, VTs, and VFib. Amiodarone has initial adverse effects that usually resolve over time, such as dizziness, nausea, constipation, sleep issues, tiredness, and headache. The long-term toxicities are the concerning ones. They include pulmonary toxicity, so patients need a chest x-ray and pulmonary function tests before starting, thyroid dysfunction and liver toxicity that we monitor with lab work, optic neuropathy, and sun sensitivity, which may lead to a blue-gray skin color. Patients are told to wear a 50-plus sunscreen all the time. Due to the increased refractory period, there is a risk of QTc prolongation, but amiodarone rarely causes torsades. It can also cause bradycardia, so heart rate is monitored closely. Dronedarone is like a cousin to amiodarone, but with a shorter half-life and volume of distribution. It is used for paroxysmal AFib and a flutter. It also has initial side effects such as GI issues, dizziness, and tiredness. It has less long-term toxicity, but can cause serious liver injury, as well as pulmonary toxicity and heart failure. Like amiodarone, it can cause QTc prolongation and bradycardia. Sotalol is an antiarrhythmic that is a weak beta blocker and a potassium channel blocker. It has reverse use dependence, so it actually has a greater effect at slower heart rates and will prolong the QT more at these slow rates. It is used for SVTs, VT, and VFib. Sotalol has many adverse effects which are common to the other beta blockers, such as dizziness, headache, brain fog, depression, changes in sexual desire or ability, and exacerbation of reactive airway disease. It has a risk of QTc prolongation and bradycardia like the other members of this class. Sotalol cannot be used in patients with heart failure or renal dysfunction, so we need an echo and lab work before starting it. Now finally, class 4 is made up of the calcium channel blockers. It only includes the non-dihydropyridines, which are diltiazem and verapamil. Like the beta blockers, they act on nodal tissue, and they block phase 2 of the action potential. As you can see in this diagram, they slow the rise of the action potential and prolong repolarization at the AB node. They decrease conduction velocity, automaticity, and increase the refractory period. You will see a lower heart rate and can have a prolonged PR interval. The calcium channel blockers are used in SVT, VT, and rate control for AFib and flutter. They have side effects of dizziness, peripheral edema, constipation, headache, and stomach upset. The non-dihydropyridine calcium channel blockers have worse outcomes in patients with heart failure, so they cannot be used in patients with left ventricular dysfunction, and we would get a baseline echo to rule this out. Thank you for listening to my presentation, and I hope it has helped you understand more about the antiarrhythmics that you will see in your day-to-day work.